Hello and welcome to your last voiceover of Adult Health 2. Today we're going to be learning about diabetes mellitus. So diabetes mellitus refers to a group of disorders that is characterized by elevated blood glucose levels. So in all types of diabetes, it results in elevated blood glucose levels. But the reason for that result can vary depending on the type of diabetes. It can either be a defect in insulin production, insulin action, or both. So insulin is a hormone that is released from the pancreas to regulate blood glucose levels. And the way that insulin works is just like this image that you see here. Insulin acts like a key that opens up the cells in our body and allows glucose to enter the cells to be processed for energy. So if we do not have adequate insulin production or an issue with the action of the insulin, with how it works, we will have elevated blood glucose levels. So that's what we're talking about in general. The types of diabetes that we're going to focus on for our module are type 1 and type 2. So we're going to talk about the differences between the two, but there are some similarities. And just so you're aware, there's other types of diabetes that you may read about in your book or see in practice. One of the other fairly common ones is gestational diabetes, and that's diabetes that just develops during pregnancy, and you will learn about that a lot more next semester. So demographics and impact. Uncontrolled diabetes can affect almost every body system. So this can affect the heart, the blood vessels, the kidneys, the nerves, and the eyes. What happens with uncontrolled diabetes is we have extra glucose running through our blood. We have high blood glucose levels. And those glucose molecules, you want to think of them as being very large and sharp. So if we have 2 or 3 or 4 times the amount of glucose in our blood than we should have, those large molecules are going to scratch the linings of the blood vessels and cause damage throughout the body. So the damaged blood vessels are going to result in decreased blood flow to areas all over our body, and that's why we end up with some of these complications. Type 2 diabetes is significantly more prevalent in African American, Native American, and Hispanic populations, and is also more common in males than females. So we have some demographics that put patients at higher risk there. And then about 1 out of every 10 patients, or 10% of patients with diabetes, will have type 1 diabetes. So type 2 is much more prevalent, but we do need to be aware of some of the differences with type 1 because our treatment differs a bit for those patients. But you'll definitely see type 2 diabetes more commonly in practice. All right, hemoglobin A1C. This is a blood test. So we draw blood, and it is the gold standard for diagnosing and monitoring the control of patients with type 1 and type 2 diabetes. So we have the ranges listed here. So this blood test results in a percentage is how it's displayed. And what it means, it's the percent of glucose that is stuck on the hemoglobin of the red blood cells. So that's why we call it a hemoglobin A1C. And because red blood cells live for about 3 months, this test allows us to see what the average blood glucose has been for that patient over the last 3 months. So instead of just getting one blood test that's telling us what their glucose level is right in this moment, it tells us what the average glucose has been over the last 3 months. So that's why it helps us with diagnosing diabetes and seeing how well it is controlled. So these are the ranges here. So normal A1C or hemoglobin A1C is less than 5.7. We diagnose pre-diabetes at 5.7 to 6.4, and we'll talk a little bit more about what pre-diabetes is on another slide. And then diabetes type 1 and type 2 is diagnosed if the A1C is 6.5% or greater. Then when somebody already has diabetes and they're trying to control it and trying to take care of it, when we recheck their A1C, which is usually done every 3 months, the goal is for their A1C to be less than 7%. So if a patient has diabetes, but their A1C is consistently less than 7%, that's how we know that they have good control, and that's how we're going to prevent those potential long-term complications. So let's talk about our first type of diabetes here, which is type 1 diabetes mellitus. So this is an autoimmune disease in which the insulin-producing cells of the pancreas are destroyed. So patients with type 1 diabetes have a total lack of insulin. So the pancreas no longer produces insulin. We have some risk factors, including family history of type 1 diabetes, viral infection. So there is a theory that patients have a viral infection like the flu, and when the body goes to attack that virus, it mistakes the beta cells in the pancreas for the virus, and it ends up attacking those beta cells that produce insulin, and so that results in type 1 diabetes. And also other autoimmune disorders. So if a patient has another autoimmune disorder or several, they're at higher risk for type 1 diabetes as well. So type 1 diabetes used to be referred to as juvenile diabetes. That's kind of an older term for it. And that's because it's most commonly diagnosed before age 30. There's about 400,000 children in the US under age 14 that have type 1 diabetes, and about 1.25 million people in the US overall. So again, that's about 10% of patients with diabetes have type 1. So these are some of the signs and symptoms of type 1 diabetes. So we have increased urination, increased thirst, and increased hunger. So when there are elevated blood glucose levels, the body tries to diurese or tries to get rid of that glucose naturally, so it will increase the amount of urine that is produced. So that's why we see increased urination. And then what goes along with that is also increased thirst, because we're diuresing. The cells themselves, because there's no insulin to unlock the cells and let the glucose in for energy, the cells are actually starving. So that will cause the patient to feel hungry, even though their blood sugar might be elevated. The one thing that sets type 1 diabetes and its symptoms apart from type 2 is going to be the weight loss. So what happens when a patient does not have insulin production is that the body can't use that glucose for energy. So in order to try to survive, the body will start to break down fat, and that breakdown of fat results in weight loss. So a lot of times when patients are first diagnosed with type 1 diabetes, they will have lost a significant amount of weight prior to diagnosis. You can also have fatigue, increased frequency of infections, rapid onset. So type 1 diabetes usually has an onset of like weeks to months, versus type 2 can be a gradual onset where they go from pre-diabetes to type 2 diabetes over several years. Patients with type 1 diabetes are always going to be insulin dependent. Patients with type 1 diabetes no longer have any insulin production, and so they rely on injected insulin for the rest of their lives. There is also a familial tendency with this, so you're at higher risk of developing type 1 diabetes if you have a close relative that has it. And then the peak incidence is from 10 to 15 years, which is going to be different than type 2 diabetes, where you're more likely to develop type 2 diabetes with increased age. I also just want to point out that the symptoms on the left side of the screen here, polyuria, polydipsia, and polyphagia, those are symptoms of initial onset of type 1 diabetes, and that's because the glucose level is high. So those are going to be similar to our symptoms of hyperglycemia that we'll talk about on another slide. So pancreatic response to glucose levels. So in a healthy working pancreas, when the blood glucose level rises, the insulin release will rise as well. So this chart here is showing that with each meal, breakfast, lunch, and dinner, we have a spike in the glucose level, and then we have a spike in the insulin production from the pancreas. And again, this would be in a healthy working pancreas. So we check blood glucose in our patients with type 1 diabetes before meals, and we administer insulin based off of the level that the glucose is and the amount of carbohydrates that they're going to eat. And that is to try to best mimic the action that the pancreas would have in releasing insulin. Okay, here we have all of our different types of insulins. So I would definitely make sure you're familiar with the onset, peak, and duration of each of our types of insulins. We have, starting with ultra rapid acting. Ultra rapid acting is a newer type of insulin that has an even faster onset than rapid acting. We don't typically use ultra rapid acting insulin in the hospital setting, but a patient might be using that at home. Our rapid acting insulins are Humalog, Novolog, and Apidra, or you can see the generic names listed there as well. So we use rapid acting insulin to lower blood glucose levels when they're elevated and to counteract the effect of meal intake or carbohydrate intake on the glucose. So those are the two reasons we would use rapid acting insulin. Short-acting insulin, like regular insulin or Humulin, Novolin. Again, we don't typically use this type of insulin in the hospital setting, but it is an option for patients at home that maybe want to take less insulin injections per day, or if the newer insulins like rapid and long-acting are cost prohibitive to them, they may use a short-acting and intermediate-acting insulins, which have generic availability now and can be less expensive. Regular insulin, because of how it works, the patient has to eat their meals at a certain time based on the peaks of that insulin. Intermediate acting, again, this would typically be given along with short-acting insulin as a basal insulin for the patient, and you might see that being used outpatient. Long-acting insulins are ones that we do typically see on the inpatient setting. So if a patient is on rapid-acting insulin for elevated blood glucose or for meals, they also have to have a basal insulin or a baseline insulin. So long-acting insulins are given so that the patient has continuous insulin coverage throughout the day, and the goal with long-acting insulin is to keep the glucose steady. So between meals and overnight and all throughout the day, the goal of long-acting insulin is to keep that glucose steady. If a patient is on the correct dose of long-acting insulin, it should not lower their blood glucose. It should just keep it steady throughout the day. So we typically give long-acting insulin and then rapid-acting insulin as needed for elevated glucose and for meals. Our long-acting insulins generally last for 24 hours, so they would give them at the same time each day. And those are our types of insulins. So just make sure you review and are familiar with that. So type 1 diabetes diagnosis and treatment, again, the gold standard is going to be our hemoglobin A1C, and a level of 6.5 or higher is going to confirm a diagnosis. They might also do a fasting blood glucose level. So because there is a rapid onset with type 1 diabetes, the fasting blood glucose may be extremely elevated, whereas the A1C might not be as elevated, so they could use the current blood glucose to also aid in diagnosis. The treatment, again, insulin is required for patients with type 1 diabetes. They need insulin every day of their lives. We do not withhold insulin from our patients with diabetes. They have to be on insulin treatment. But some other things that are going to help with controlling the blood sugars with type 1 diabetes are going to be nutrition management, so specifically learning how to count carbohydrates. So the patients need to learn what types of food have carbohydrates, how to read nutrition labels, and be aware of how many carbohydrates they should eat with each meal and what that looks like with their insulin regimen. So type 1 diabetes management is very specific to the patient, and these things can vary a lot patient to patient. Obviously, we have to do a lot of patient education, self-management. So these patients need to know how to check their own blood glucose, how to administer their own insulin, symptoms of high and low blood glucose, and what to do if their blood glucose is low or high. So type 1 diabetes and diabetes in general is very much managed by the patient day to day, and so they need education, they need to feel comfortable on how to perform those skills and what to watch for. And with this being diagnosed in children a lot of that education will go to the parents, which if you're taking care of an adult patient with type 1 diabetes, you want to assess if they have received that education or if that information was passed along from their parents to them, because that can be a difficult transition when they are responsible for managing their own diabetes as adults. We're also going to watch for complications with patients with type 1 diabetes, or teach them how to watch for complications. So we have a few acute type 1 diabetes complications. So we talked about our long-term or chronic complications are going to be things like cardiovascular disease, kidney disease, retinopathy, neuropathy, but these are more of our acute complications. So diabetic ketoacidosis, you're going to go into a lot more detail on this disorder in semester 9, so we're just going to focus on the basics. But basically, when a patient with type 1 diabetes has held or not given their insulin injections is a common cause, or if they're severely ill or dehydrated to the point where it's difficult for their body to use the insulin properly, the body's going to start to break down fat, like we talked about, for energy. And that's going to result in this ketone release, which causes acidosis. So DKA can be fatal. It's a very common reason for ICU admissions for patients with diabetes and type 1 diabetes specifically. And so it's something that we want to watch for and we want to educate our patients on. What I want you guys to focus on is the ketone part of this. So if ketones are developing in a patient with type 1 diabetes, if ketones are present in their blood and their urine, that means that we either have a lack of insulin or we have an issue with their body using the insulin. So they're at risk for going into this DKA. We can check ketones in the blood, or more commonly, we check them in the urine. So just be aware if a patient has positive ketones in their urine or their blood, we're concerned that they might be going into diabetic ketoacidosis. And we need to evaluate if they have gotten their insulin or if there's an issue with the absorption of their insulin. And then, of course, hypoglycemia. So because patients with type 1 diabetes are taking insulin every single day, there's always the potential that too much insulin might be administered, or there's several other factors that can lead to hypoglycemia, like increased activity, lack of carbohydrates in the food, lots of different reasons that we might end up hypoglycemic. So we want to watch for symptoms of hypoglycemia and educate our patients on symptoms of hypoglycemia and the treatment. And we'll talk about that on another slide. But that's definitely a big concern with anybody on insulin or medications that can cause a low blood sugar, because hypoglycemia can be fatal as well. The brain relies on glucose to function, and so when our blood sugar is severely low, there can be seizures, coma, and death. So we definitely have to make that a priority in our care of patients with type 1 diabetes. And here are our hypoglycemia interventions. So again, it can be minor or severe. Patients with diabetes can definitely treat their own hypoglycemia by ingesting glucose, but it can be severe to the point where they need medical assistance. Severe hypoglycemia can be life-threatening. It mentions hypoglycemia unawareness here, so I just want you guys to be aware that patients with diabetes, if they have had a lot of hypoglycemia episodes in their life, the body starts to respond differently or has a lack of response to hypoglycemia. So when we're hypoglycemic, our body should have the response of that shaking and sweating and dizziness and irritation. But for some patients that have had frequent or severe hypoglycemia for a long time in their life, their body just doesn't react the same way. So they might feel completely normal with a blood glucose in the 30s. So the only way that they know if they are hypoglycemic is by checking their blood sugar. So just be aware that some patients might experience that and what that term means. And then what do we do for our hypoglycemic patients? So this is our 15-15 rule. We give 15 grams of rapid acting carbohydrates. So that's like 4 ounces of juice, 4 glucose tablets, a package of glucose gel. It has to be rapid acting, so it can't be things like chocolate or graham crackers or fruit, because fruit has fiber in it that slows down the action of that glucose. So it has to be rapid acting. Depending on where you work, the treatment that facility requires you to give might be different. I've worked at places where we could give juice from the refrigerator, and I've worked at places where you had to get glucose tablets out of the Pyxis, just like any other medication. So it might vary, but just be aware it's 15 grams of rapid acting glucose, and that's what we would educate our patients on as well. And then the other part of the 15 is that we recheck the blood sugar in 15 minutes. So we want to see if it's back to a normal range, which is usually back above 70. And if it is not, if they're still hypoglycemic, we just keep repeating that 15-15 rule until the blood glucose rises to a normal level. So here is our 15-15 rule for hypoglycemia treatment. So we check the blood glucose. If the level is less than 70, we have the patient eat or drink 15 grams of fast-acting carbohydrate and then wait 15 minutes and recheck. Again, if the level is still less than 70, we're going to repeat this until the level becomes above 70. If the patient is not able to swallow or eat fast-acting carbohydrates, like if they just had a stroke, for instance, and they're on their NPO status, or if the patient is having a seizure or is unconscious due to the hypoglycemia, or any variety of reasons why they cannot take glucose orally, we have a couple pharmaceutical options that I believe you guys have reviewed in pharmacology. One of them is glucagon, so that's an injection that's given IM, and glucagon is a hormone that stimulates the release of stored glucose from the liver. So that would be an option for a patient to use outpatient. So some patients that are on insulin or that have type 1 diabetes will carry around a glucagon that could be used in an emergency. And then if a patient does have IV access, we prefer to use D50 or dextrose 50. It's an IV push of literal dextrose into the veins, and that's how it increases the glucose levels. So those are some other options for patients that cannot eat or drink. Okay, so assessment of patients with type 1 diabetes. Again, we're going to assess what their self-management is, how often are they checking their blood sugar, what type of insulin are they taking, what is their diet. We want to assess where they are at with their self-management, what education might they need. We always do our vitals. We're going to check our serum glucose level. We check potassium levels because insulin can have an impact on the potassium levels. So you guys might recall from a previous module that one of our treatments for high potassium or hyperkalemia was IV dextrose and insulin. And just as a refresher, that's because when the insulin opens up the cell to let the blood glucose in, it also opens up to let the potassium in. And so insulin can lower potassium levels. So we want to monitor their potassium level, their intake and output to see if they are having fluid level issues. We want to assess their carbohydrate intake at meals to determine if it's appropriate for their diet and for their insulin regimen. We would look at a BMP to monitor kidney function to assess for potential chronic complications as well as their potassium level. Weight changes because sustained hyperglycemia, especially if it's caused by lack of insulin for these patients, is going to cause a weight decrease. And then we're going to assess for ketones to see if the patient is spilling ketones into their urine or blood, which means that they have a lack of insulin or insulin use in their body. Nursing interventions and patient education for patients with type 1 diabetes. We're going to be monitoring that bedside glucose. Typically, our order for that, unless the patient is in an ICU setting on an insulin drip, is going to be before meals and at bedtime. We're going to administer insulin as ordered, and we can administer isotonic IV fluids that can help to flush out some of that excess glucose and rehydrate our patients as needed. We're going to teach our patients about the signs of low and high blood sugar, how to administer their subcutaneous insulin. So remember, if a patient is being discharged or will be discharged, and this is going to be their first time giving themselves insulin, we need to make sure that they are comfortable with the process of both drawing up and administering the insulin. For certain patients, like with dexterity issues or vision issues, this can be quite a challenge. So we want to start working on this and planning for how they're going to administer their insulin before it's time for discharge. We'll do medication education, educate them on when and how to monitor their blood glucose and ensure that they have a prescription for a blood glucose monitor, and then provide education on healthy diet and lifestyle modifications like regular activity. Okay, insulin administration. So the images here are showing you a variety of ways that we can administer insulin. So of course we know that we can administer insulin subcutaneously via a syringe after drawing the insulin into it from a vial, and for that we use only insulin syringes. So definitely remember that. As you're taking care of patients, we only ever draw up insulin using an insulin syringe, and that's because insulin is measured in units, and we have units on our insulin syringes that we do not find on other syringes that would have milliliters. So we always draw up insulin using an insulin syringe. We also have on this image insulin pens. Insulin pens are another option. Some hospitals actually use these. What an insulin pen is it's a preloaded vial of insulin within that pen. And each time that you give an injection, you connect a needle to the end of the pen. It screws on like a cap. And then you dial. So you can see on the far right side of that pen, you dial the number of units that you want to administer. Insert the needle into the skin and then press the button down, and that will administer that amount of units. So again, some hospital systems do use these inpatient, but it's also a good option and something you could advocate for your patient to use at home and get a prescription for if they have vision or dexterity issues that make it difficult for them to use syringes and vials. We also have an image here of the locations where we can administer insulin, so abdomen, the back of the arms, the buttock, and the thighs are some of our options. Remember that for most patients, we can inject insulin subcutaneously at 90 degrees, but if they have a minimal amount of body fat, we would need to insert the needle at 45-degree angle to make sure that it's in the subcutaneous tissue. The last image over there on the right-hand side is of a continuous glucose monitor and an insulin pump. So an insulin pump is another option for administering insulin. There is a subcutaneous port attached to the patient that is connected to a vial of insulin or a syringe of insulin within the pump. There's only rapid-acting insulin in pumps, and there are many settings within the insulin pump that determine how much insulin the patient will get throughout the day. The continuous glucose monitor is a sensor that measures the glucose every 5 minutes and sends that reading either to a cell phone or another device. So that is an alternative for patients. Instead of finger stick blood glucose monitoring, they might have a continuous glucose monitor. Okay, so let's talk a little bit more about insulin pens and insulin pumps. So insulin pens allow the patient to dial the exact dosage, avoiding potential errors with measuring and withdrawing insulin. These are great for patients with visual impairment. You would be surprised at how difficult it is for some patients to draw up insulin with a syringe and a vial. It might be fairly simple for us, but even some of us might have struggled with that skill initially. So having to hold the vial while you're holding the syringe and pull to the correct number, for a lot of our patients, that's going to be difficult. So an insulin pen would be a great alternative. Now, insulin pumps are a continuous subcutaneous delivery of rapid-acting insulin. We only have rapid-acting insulin in an insulin pump, so the patient does not take any long-acting insulin. There's a setting programmed within the pump that delivers a certain number of rapid-acting insulin units per hour for the patient, and that is their basal or their baseline insulin. And then additional insulin can be bolused from the pump for high blood sugar or when the patient is eating carbohydrates. And that's kind of the basics of how insulin is delivered via an insulin pump. Again, there's insulin in the pump, and it is connected to a subcutaneous port on the patient that the patient changes every 2 to 3 days, and that's how it is infused. So some benefits of insulin pumps. Again, we don't need to go into a great deal about insulin pumps, but they are becoming more and more popular. More and more patients are using them. So as general nurses, we may be taking care of patients that either come into the hospital on an insulin pump. They may continue the use of their insulin pump while in the hospital if the provider orders that. So there's just some safety considerations that we need to be aware of as general nurses around insulin pumps. So the benefits are convenience. So they don't have to take out a syringe and a needle to give their insulin. It's right there in a small device connected to them. Better glucose control, and the ability to deliver smaller increments of insulin. Insulin pumps can deliver tenths or 100ths of units of insulin, so a much more smaller increments for a little bit tighter control of the blood sugar is an advantage. There are disadvantages though. There's a high cost associated with insulin pumps. Most insulin pumps cost around $8,000, so the patient would, and then there's the supplies that are needed every month to go along with the insulin pump. So the patients would most likely have to be on some type of health insurance to be able to afford an insulin pump. There's also intensive education and participation by the patient. The patient has to go through an education course to learn how to use their pump, and then it requires very frequent active participation by the patient throughout the day when they're using an insulin pump. They have to know what their blood sugar is. They have to be monitoring for hypo and hyperglycemia. They have to, maintain the insulin pump site, maintain the insulin within the insulin pump. They have to provide boluses when they're eating or when their blood sugar is too high. So it's not something we just put on a patient and it's going to control their diabetes. They really have to be an active participant. So for that reason, it's not a great option for a patient that is not very active in their diabetes management. Like if they don't like to check their blood sugar or they're already not taking their insulin injections, it might not be the best option for them. You can also have skin issues. So with the subcutaneous port site, obviously, that can get infected or irritated. And then we can have pump malfunctions. So the pump itself could stop working. It is a piece of technology. Batteries might die. You can have issues with the actual subcutaneous port where it is not delivering the insulin properly. And the risk is higher with an insulin pump because there's no basal insulin. So if the infusion of insulin stops for whatever reason with an insulin pump, the patient is at higher risk for developing ketones and developing that diabetic ketoacidosis that can be critical. So they need to be constantly monitoring to make sure that the pump is functioning properly. This can be used for type 1 or type 2 diabetes. So this is not just only for type 1 diabetics, but type 2 as well, if the patient requires multiple daily insulin injections and are otherwise a good candidate based on the things that we just discussed. Okay, post-insulin administration. So we want to be aware of the peak times for our different types of insulin because that's when we're going to be most high alert for hypoglycemia. Dosages of insulin can be adjusted when the client is scheduled for procedures that require fasting. So if they're fasting, we won't be giving mealtime insulin that is intended for when they're eating, but we may still give insulin to correct a high blood sugar, and we would always still give long-acting insulin. We always need to have a basal insulin on board because our liver is constantly putting out a little bit of glucose and we need something to counteract that. Otherwise, the glucose will be elevated and we will also start to break down fat for energy and develop those ketones. So we always give long-acting insulin, but the dose may be adjusted. Prior to discharge, we want to observe the client perform self-administration of insulin. So we actually want to watch them complete that process. Okay, so type 2 diabetes are more popular. About 90% of our patients with diabetes have type 2. And you can think of type 2 diabetes as insulin resistance. So the pathophysiology is that the cell membranes of the cells within the body resist transport of glucose into the cell. So they are resistant to that insulin. So a patient with type 2 diabetes, their pancreas is still working to produce insulin, but the cells are resistant to using that insulin. So you have a production of insulin, but you have a resistance to using it. So what happens then is if the type 2 diabetes is not controlled well, the pancreas will continue to put out more and more insulin, and eventually, typically after years and years, the pancreas almost starts to give out or starts to fail because it has been overworking for so long trying to overcome this insulin resistance. So eventually that's why you will see patients with type 2 diabetes on insulin therapy. But initially and overall, the treatment of type 2 diabetes is aimed at decreasing insulin resistance. This is just some epidemiology. 11.6% of the population of the United States has type 2 diabetes in 2024. So that is pretty daunting, and that is why it is so imperative that we as nurses understand the management and the education that goes along with patients with diabetes, because if 11% of the general population has type 2 diabetes, even a larger percent of our patients are going to have type 2 diabetes because they're going to have comorbidities and be at higher risk for things that would end them up in the hospital. So I've had shifts where every single one of my 5 patients has type 2 diabetes. And because if we don't control their blood sugars well when they're in the hospital, we're going to put them at increased risk for infections, delayed wound healing, extended stays in the hospital. We have to have a good understanding of how to take care of these patients properly. And then it is more common in adults than juveniles, although with the epidemic of childhood obesity, there is definitely an increase in the amount of children that are being diagnosed with type 2 diabetes as well. Okay, so type 2 diabetes screening. So we would want to screen any patients who have a BMI above 25, so they would be overweight or obese, and one or more of the other factors listed there. So if they have a first-degree relative with type 2 diabetes, age over 45, sedentary lifestyle, history of vascular disease, polycystic ovary syndrome, PCOS, gestational diabetes. So if they've had diabetes during pregnancy, now they're at higher risk for type 2 diabetes after pregnancy, or giving birth to an infant weighing more than 9 pounds. If they are African, Hispanic, Asian, American Indian, or Pacific Islander heritage, they're going to be at higher risk. Patients that have hypertension, so a blood pressure consistently greater than 140/90, hemoglobin A1C greater than 5.7, so that would indicate pre-diabetes. So of course, if somebody has pre-diabetes, they're going to be at higher risk for developing diabetes type 2. Also, if they have impaired fasting glucose, impaired glucose tolerance tests, or dyslipidemia, so HDL level less than 35 or triglycerides greater than 250. So essentially those are all of our known risk factors for type 2 diabetes. So if they have 2 or more, we're going to be screening them, doing the hemoglobin A1C and fasting blood glucose to see if they have diabetes. All right, so let's talk about pre-diabetes. So clients are considered to have pre-diabetes when the hemoglobin A1C is elevated, but not high enough to diagnose. So I would always like to tell my patients that had an A1C that indicated pre-diabetes that this means that there is a problem, right? This is a warning sign. So your body is becoming resistant to insulin to the point where it's not able to control that glucose well enough to fall within normal parameters. So pre-diabetes is great to be aware of because then we can make changes to those modifiable risk factors to prevent the patient from developing type 2 diabetes. So diet changes and exercise are recommended, and to have their hemoglobin A1C rechecked to make sure it's not increasing. Okay, so here are some of our type 2 diabetes symptoms. Again, you're going to see things similar to what we saw with type 1 diabetes that indicate hyperglycemia. So that's going to be increased thirst, blurred vision, increased risk of infections or increased infections, increased urination. You can also get symptoms like tingling and numbness in the hands and feet. That's going to indicate potential damage to the nerves from elevated glucose, or we call it peripheral neuropathy, increased hunger. Some of the things on here that are particular to type 2 that we're not going to see with type 1 is going to be excess fat and obesity. So remember with type 1 diabetes, they have that breakdown of fat for energy. With type 2, they still have insulin in their body, so they're not going to be breaking down that fat. But increased fat or obesity is a risk factor and is associated with type 2 diabetes. So remember, increased weight with type 2, decreased weight with type 1. They can also get dry, dark patches of the skin. That's indicative of insulin resistance. You might see that on patients. Okay, again, here are type 2 risk factors: a high BMI, physical inactivity, dyslipidemia. Metabolic syndrome is a cluster of disorders that puts the patient at higher risk for type 2 diabetes. So you might hear it referred to in that way, but that would be like dyslipidemia, hypertension, and some of the things that we have talked about. pre-diabetes, and then family history. So think about which of those are modifiable and which are non-modifiable. What can we address with education and goal planning with our patients? Okay, type 2 diabetes and treatment. Diagnosis. Again, it's going to be the same. We're doing a hemoglobin A1C is going to be the gold standard. We can also do fasting blood glucose, 2-hour postprandial, so that's post-meal blood levels, or a random blood glucose. And those all have normal ranges. And if it was elevated, that would indicate diabetes. But we really do need that hemoglobin A1C for diagnosis because, again, that's going to tell us the average blood sugar over the last 3 months. So as far as treatment, medications, our first line is typically going to be metformin. So that would be an oral anti-diabetic. But depending on the patient's current blood glucose and their hemoglobin A1C, and particularly a lot of times in the hospital when the patient's already experiencing complications, we will sometimes start patients on insulin initially, but that is not always the case. We can absolutely start with oral anti-diabetic agents. We're going to monitor their glycemic control with bedside glucose monitoring and A1Cs. Education and goal planning for modifiable risk factors. So diet. So they're going to want to have a healthy diet similar to what we talked about with cardiovascular. So low sodium, low fat, but most importantly for glucose control is going to be a controlled amount of carbohydrates. So we don't want patients to stop eating carbohydrates entirely because they are an important part of the diet and part of how we get our energy and our nutrients. But they need to have a controlled amount throughout the day and be aware of what types of foods have carbohydrates in them. Exercise, so the recommendation is 150 minutes of moderate activity per week for exercise, and a weight loss of 5 to 10% is shown to improve glucose control and potentially prevent prediabetes from going to type 2 diabetes. So that is the weight loss recommendation. And then again, we want to monitor for all those complications that can happen from diabetes and particularly uncontrolled diabetes and hyperglycemia, like our cardiovascular disease, kidney disease, hypertension, vision issues, and neuropathy. Okay, so our oral anti-diabetic medications are listed here. Our metformin. So what I want you guys to focus on with these medications, and particularly the ones that I have highlighted in red, is going to be the mechanism of action. I know this might be some review from your pharmacology class, but I'm going to go over the mechanism of action for the ones that I have highlighted in red here. So for metformin, our biguanide, that's going to reduce the glucose production in the liver, so reduce the amount of glucose that's circulating in the blood, and then it also decreases insulin resistance. So it helps your cells with using the insulin that's already circulating in the system being produced by the pancreas. So metformin we like to use because it does not have the risk of causing hypoglycemia, and it can improve that insulin sensitivity. Our sulfonylureas, or second generation sulfonylureas like glipizide, glimepiride, and glyburide, they actually increase insulin secretion from the pancreas. So that can definitely be helpful in controlling the glucose levels, but there is that risk of hypoglycemia with these medications. So when you're doing your medication review of a patient that's been admitted to the hospital, you definitely want to know if they are on a sulfonylurea, especially if they're going to be NPO, because if that medication is still in their system, they're at high risk for hypoglycemia. So in practice, I've seen this medication used less and less, but we do still need to know about it for our module. And then our SGLT2 inhibitors, or sodium glucose cotransporter 2 inhibitors, like canagliflozin or dapagliflozin, Those are going to work by decreasing glucose reabsorption. So they're going to cause more glucose to be released in the urine. So they work in a little bit of a different way to decrease those blood sugar levels. All right, so some acute type 2 complications, a little bit different than our acute type 1 complications. This is going to include hyperosmotic hyperglycemic state, which we refer to as HHS. Again, you guys will go into more depth about that in semester 9, but this is seen with extremely elevated glucose levels and extreme dehydration. So our elderly clients are going to be at more of a risk for this. The treatment is going to be similar to DKA treatment, which is IV insulin and IV fluids. And then we can have a depressed immune system. Really, that can happen with uncontrolled type 1 diabetes as well. But bacteria love glucose. So if we have a lot of extra glucose circulating in our system, we're going to be at higher risk for developing an infection. And then elevated glucose or hyperglycemia affects the production of white blood cells. So it's going to be more difficult for our body to heal from an infection or heal a wound. So it's kind of a double whammy with how hyperglycemia puts the patient at higher risk for infections. Okay, here are symptoms of hypo versus hyperglycemia. Depending on what resource you look at, you might see different ranges associated with hypo and hyper, but in general, hypoglycemia is going to be less than 70 milligrams per deciliter. So that's usually when we treat hypoglycemia in the hospital, and what you might see with that is mild shakiness, confusion, diaphoresis, palpitations, headache, lack of coordination, so issues with balance, blurred vision, and then in an extreme scenario, you could see seizures or coma. So again, the central nervous system is heavily dependent on glucose for functioning, so that's why we see some of these neuro symptoms with low blood sugar, and that's also why we can have a seizure and a coma with extreme low blood sugar, blood glucose. And then with elevated blood glucose, which can be anything above 130, usually we treat above 150 in the hospital. So usually your correction sliding scale will start at 150. We're going to see with this hot and dry skin, fruity breath, that's usually related to those ketones that we talked about can cause fruity breath. We have our 3 Ps, polyuria, polyphagia, polydipsia, so increased urination, hunger, and thirst. Fatigue, they don't have a lot of energy because their body can't process that glucose for energy. Blurred vision, and tachycardia. So be familiar with the symptoms associated with each of those that we need to watch for in our patients or educate them about. So assessment for patient with type 2 diabetes, we're going to assess their vitals, their glucose levels, how are they managing their diabetes. We would do a skin assessment to look for any wounds. Again, intake and output to assess for fluid volume issues, a BMP to assess their kidney function and electrolytes, and then their carbohydrate intake at meals. So nursing interventions and patient education, these are going to be similar to our interventions for type 1 diabetes, blood glucose monitoring. We don't typically use oral anti-diabetics in the hospital setting. So depending on where you're working, you may or may not be administering those. The reason we use insulin in the hospital setting is because it is quicker and more effective for the management of elevated blood glucose levels. So if a patient's glucose is 250 and we give them a sulfonylurea, it might take an extended period of time for that blood sugar level to drop, whereas if we give 5 units of rapid-acting insulin, it can drop within a few hours and we can get them back into that goal range that's going to help them with healing. On the other hand, if we need to back off on insulin or anti-diabetic medications because the patient needs to be NPO tomorrow for a procedure, if we try to take them off of oral medications, it's going to take a longer period of time for that to get out of their system and stop having an effect, versus if we stop a rapid-acting insulin, it'll be out of their system in about 4 hours. So we can get tighter control of the blood sugar and make more frequent changes based on the patient's condition with insulin than we can with oral antidiabetics. You've probably also heard about how, for instance, metformin can't be given when a patient has gotten contrast dye because it increases the risk of acute kidney injury, so we have those considerations as well. We may administer isotonic IV fluids and antibiotics as needed. Again, we're going to be teaching about glucose checks, insulin, if they need education on insulin administration. What happens with patients a lot of times is they are admitted to the hospital and they are not on insulin, but they've had maybe a severe infection, maybe they are on steroids and they have an elevated glucose level now, and so they're going to go home on insulin. So again, we would need to teach them about how to perform that skill, healthy lifestyle education, and foot care, which we will talk about on another slide. And here is that slide. So foot care is very important for patients with diabetes. Elevated glucose levels are going to impair the blood flow to the feet, and then we already know that they're at higher risk for infection. There's also the chronic complication or long-term complication of neuropathy, which can cause numbness in the feet. So they have a lot of risk factors for having wounds on their feet and for those wounds not healing properly. So these are the education points that we are going to teach our patients about, and we're also going to be inspecting their foot when they're their feet when they are under our care. So wash feet daily and dry thoroughly, including between toes. So we don't want to leave any moisture between toes. That's going to foster infection. Do not soak feet unless specified by a healthcare provider, because that could also increase the risk of infection. Be careful of hot water, and that is because if a patient has numbness in their feet, they might not recognize how hot the water is, and they could cause a burn to their feet. I actually had a patient once that had pretty severe peripheral neuropathy from diabetes, and she walked out onto her driveway in the middle of summer to talk to a friend with no shoes or socks on, and the bottom of her feet actually burned off, and she didn't even realize because she had no feeling in her feet whatsoever. So there's definitely lots of risks here with the feet. We also want to use creams, lotions, or moisturizer, but not between the toes. Do not walk barefoot. Again, my patient could have benefited from that education. Use caution in cutting nails. So you might hear about patients with diabetes needing to go to the podiatrist to have their nails cut. It kind of just depends on the patient and if they have peripheral neuropathy, but we definitely want to use caution. And then wear properly fitting footwear. I had another patient that was working a construction job, and he stepped on a nail and it went through his shoe, and he didn't realize until his shift was over that there was a nail in his foot, and he did get an infection for that. So even checking things like that, depending on the patient's occupation, would be important. Okay, patient management. Just remember, we're collaborating with a lot of different disciplines to take care of patients with diabetes. We're going to collaborate with the pharmacy, maybe to check the medications that we're sending home with them, what education they might need, what barriers they might have, the cost, those types of things. Dietitian, absolutely. These patients benefit from a diet review and diet education. Diabetes care and education specialist, so that used to be referred to as a certified diabetes educator, so you might hear those terms interchangeably. Unfortunately, there's very few hospitals in the Valley that have one of these specialists on staff, but if you have one, it's a great resource to do a consult with your patient to review their self-management and their education. And then their primary care physician. So we always need to be referring a patient that's being discharged from the hospital to someone that is going to continue to monitor their diabetes and their glucose control, because this is an ongoing chronic disorder. And so we want to make that clear to our patients that this isn't something that's going to clear up after taking insulin for 2 weeks. They have to continuously be taking care of this and be monitored. So you could refer them to their primary care physician or an endocrinologist. Okay, this is again just the long-term diabetes complications. So we have macrovascular, which is large vessels, versus microvascular, small vessels. So our macrovascular complications are cardiovascular disease and cerebrovascular disease, like hypertension, MI, and stroke, as well as diabetic nephropathy, so damage to the kidneys from prolonged elevated glucose levels. And then we have microvascular complications like diabetic retinopathy. So this can actually cause blindness. That's a very serious but fairly common of severely uncontrolled diabetes or hyperglycemia. And then diabetic neuropathy, which again is numbness and tingling in the hands and feet, that can also be very severe to the point that they cannot feel their feet at all. And just as a side note, the way to prevent all of those complications is going to be having that A1C level less than 7% and having good glycemic control. That's going to help prevent all those complications. Okay, so sick day rules. There's a couple things that we need to educate patients about that have diabetes when they are sick. So when they have a cold or flu or a GI bug, to help prevent them from having complications from that related to their diabetes. So we want patients to continue taking their diabetes medications as usual, their insulin, diabetes pills. I would say the only caveat to that is if they have insulin that they take specifically for a meal and they're not eating, they wouldn't want to give that insulin. But otherwise, in general, we want them to take their insulin and diabetes pills as usual. Test their blood sugar at least every 4 hours, maybe even more often, if they're having issues with their blood sugar. Drink extra calorie-free liquids. So we want them to stay hydrated because dehydration can increase the blood sugar. They want to weigh themselves every day because if they're losing weight, that could be a sign of hyperglycemia or of ketones. Check their temperature every morning and evening. They want to monitor for infections. So again, patients with diabetes with uncontrolled blood glucose are going to be at higher risk for an infection or for severe infection. So they want to monitor for that. Drink plenty of fluid, so 4 to 6 ounces every half hour to prevent dehydration. And if they are not able to eat solid foods, they can replace their food with beverages that have carbohydrates like juice or Gatorade. We want to educate our patients with diabetes to go to the emergency room if they're having trouble breathing. If they have moderate to high ketone levels in their urine, so patients can get over the counter or as a prescription strips that they urinate on, and it will tell them their level of ketones. If they can't keep any liquids down for more than 4 hours, if they lose 5 pounds during an illness, if their blood sugar is lower than 60, I would say if they are not able to treat their blood sugar or to get it to rise above 60 after treating it, they could seek emergency help. If they're too sick to eat normally or unable to keep food down for 24 hours, if they have vomiting or severe diarrhea for more than 6 hours, that's going to put them at high risk for dehydration. If they have elevated temperature over 101 degrees for 24 hours or feeling sleepy and can't think clearly, they would have somebody call 911 or take them to the emergency room. All right, and here are some patient resources. The American Diabetes Association website is a great resource for us and for patients. And then we have the American Association of Clinical Endocrinologists. We will review these questions in class, and I'll see you then.